So we have a lot of questions from the audience. So I will keep my questions to the end if there's time. And also like I know many of you in person, so I have this kind of privilege to ask you in person as well later on. So maybe Holly, since I had you like last, I will start with a question from the audience to you. So the question is saying it's mainly talking about privacy. So they're asking, can you talk about the potential privacy issues associated with tools like Go Guardian Beacon? Are there ways to help determine suicide risk in students without using such invasive surveillance tools?
Yeah, that is the key question. That's a very, very smart question. And this is the issue that always comes up. And the way that it was set up here in Baltimore is that students they sort of signed when they went in to use a Chromebook, if they were using Chromebooks during the pandemic, or before actually Go Guardian was started, they clicked on a sort of a checkbox indicating that they were willing to participate. And so there was that notification that they had. But the way I look at it, and from what I've seen and heard from our emergency department, and the fact that kids are being monitored all the time, if they're on TikTok, if they're on anything else, they're being tracked. There is not privacy as the way we would like there to be privacy. And so I think that's the world that we're in right now. And if these types of tools can save lives, then I am all for them. I just, the situation that we have experienced in Maryland or in Baltimore is this issue with the resource officers going out to the homes after hours. If someone's identified when they're not in school, and that means that someone needs to go to their home to alert the family. And when this has happened, oftentimes the families were so relieved that someone actually came out and told them that this was going on. And yeah, so there are privacy issues, but I feel as if they can save lives, they're really worth consideration and careful study.
Yeah, maybe Daniel and Philip, maybe you can talk more also about the privacy concern, because it's something that everybody obviously is concerned about. So maybe we start with Philip.
Daniel unmuted first. He should go.
Oh, go ahead. Sorry.
Okay. Yeah, I did briefly allude to it in my talk. I mean, it's a major concern for service members, right? Because so many of our efforts are focused on breaking down barriers and stigma for getting care in the first place, especially in our system. Keep in mind, I work in the DoD, and they have a job in the DoD, right? So in addition to being the folks that are providing healthcare for them, we're also the folks that are employing them. Imagine if you had that conflict with your civilian programs, right? That it was actually their employer who was finding out that they had this issue. Now, obviously, we have things in place so that their commanders and stuff don't find out, but that doesn't mean they don't think that way, right? So it's a massive concern for us. It's, to be honest, before we do anything with respect to trying to engage service members and connect them to care, we consider that issue. And as I kind of alluded to in the talk, it really is one of the main reasons that we probably, with most of our programs, have taken more of the approach of trying to make it easier for them to come to us than trying to specifically go out and find them. Now, our programs want to find them at a population level, right? At the population level, we're going out and we're trying to offer information and break down barriers. But as far as at a risk level, we see, I personally see a lot of concerns with privacy and amenity there.
Yeah, so I guess I would take this from two angles. The first is that individuals' agency and consent is hugely important, obviously. It's one of the reasons that I started with the Coppersmith paper, which used his data donation platform in order to get the data. At the same time, I think that a lot of people's concerns about privacy, the people that you're asking, hey, could we get your consent in order to do this, that we might be able to help you? People just don't have a very good understanding of the issues and the trade-offs. If you ask a bunch of people, did you give permission to various apps you have to tell them who you're sleeping with? Most people are going to say no. And then if you ask them, do you have location services turned on? A lot of people are going to say yes. And as a result, the app knows where your home is because that's where you're spending the night most of the time. Where are you spending the night when you're not at home? Well, good chance that's who you're sleeping with. So people are not aware of how much information they are giving up to people who are not defined in terms of doing things in their best interests and connected with institutional review boards and policies and so forth. Right? So I think a part of the consent issue is the informed part. Informed is not, I believe, just about information about the risks, right? These criteria are about risks and benefits. And so these things need to be put properly into context. And I think there is an enormous legitimacy to concern about privacy, and we need to take that into account. And at the same time, I also think that there's a big skew in how we pay attention to those issues, focusing on the risks and sometimes not balancing those with the current state of affairs and the potential benefits.
I agree. And I think also, like, this is where the role of policies come in. Like if you have some policies, then you can regulate certain things. I always think also about this documentary Social Dilemma. After watching it, you kind of feel like, oh my God, like what should I do? What is the right solution? And I feel a lot of these questions we kind of face even like while parenting and stuff like that. So they're very important questions. Another question to Dan, so you got a lot of questions, so I will pick one of them. So one of the audience said, thank you for your very helpful explanation of the sensitivities concerned about rare events. I wonder if you could relate this back to your use case scenario. Might the cost of false positives be different for care providers than the health system level? That is, could a psychiatrist or counselor make use of a top 10% sample model, which has very good sensitivity?
Right. So this is an excellent question. The analysis that I present, it all depends entirely on what your system is, right? I think one of the things one thing about the military health system that a lot of people don't know or assume is that it's primarily an occupationally functional, normal population, right? They're service members, so people think immediately of that, but we're talking almost 10 million people that get TRICARE, a normal population of largely healthy people who are going into, we're pretty much the only system in the United States where everyone all the service members have to go in and get screened every single year, right? So we definitely, in the balancing act of how clinical your population is, even though we have these unique exposures of potential like battlefield exposures and stuff, we have a very healthy population, right? And so when you're doing that balancing act of trying to determine if we do a population level screening, how many of those false positives are we going to get? I think we're a little more skewed towards, having a lot of healthy people coming in who in any other healthcare system wouldn't have gone in for an annual checkup, right? But in our system, because we make them, they come in as potentially being false positives. So that's first off, just for kind of like a bigger picture. And I think more specifically, absolutely, if you have a specialty care environment, right, with a psychiatrist or clinical psychologist, whatever, in that environment, their equation is going to look differently. And that's why I started off that talk with, this simulation that we presented was our population and our data and how this works with us, right? But I think those are the correct questions you have to ask and the correct information you need to have in order to see if you're going to move the needle in some kind of meaningful way on the suicide mortality outcome for different contexts and different populations. So the answer to that question is absolutely it could be different, and you should look, right? You should look, or you should defer to some good research that's looking, and I think you might find some slightly different things in different populations, but you're still not going to get away from those primary concerns that I brought up and other people have been bringing up as well.
That's very true. So there's a question for Philip, but I would like to hear also from Holly and Daniel as well. So this is a dear topic to me, so I'm going to be biased and pick that question. It's about health disparities and bias. So it's asked like, does the research take into account any disparities that may have occurred and are shown in the data that may have been outliers? So I will start with Philip since it was addressed to you, and then we will move to Dan and Holly.
Yeah, so I was going to follow up on what Dan was saying a second ago, even before that question. You were talking about different populations, and my immediate response, as usual, is to jump up out of my chair and say, yes, but where do you get the data, right? Especially if you're talking about subsets of the population or intersectional categories in the population, it gets even more difficult, right? So if we don't address the data problem, we can't address any of this other stuff. And by the way, I was thrilled to hear Holly saying that there's VA data that is mixed in with the Maryland data as opposed to it being in its own completely separate walled garden, because I know VA has a big set of its issues as well. In terms of the question about disparities, I think this gets to the point, right? Many of the systems that we have there's an entire subcommunity in AI working on fairness, accountability, transparency, and ethics, FATE, FATE. And we know that there are existing disparities that are exacerbated by using the data that we have available in order to train the systems that we've got. And so I'm not going to go on at length about it. I think there are techniques that you can use to try to detect that. There are technical things that you can try to do to make your systems less susceptible to it or remove that stuff from it. And, a whole technical discussion to have about why systems are like this. But the bottom line is that unless you have a good picture of the population in terms of the data you're using, then you can't, it's very, very difficult to address these issues. And that's the nut we need to crack.
Thank you. Holly or Dan, whoever wants to follow.
I'll go next. I'll just be really quick. And just to say that this is a major emphasis on the Maryland suicide prevention warehouse or suicide data warehouse project that we have now. We're in a fairly diverse state, and we're looking really at these issues of predictive modeling and how models perform in the general population and in specific risk groups, diverse risk groups by race, ethnicity, and other characteristics. And so this is something that we're trying to pay a lot more attention to.
Yeah, I would just quickly add, I think Dr. Reznick and Dr. Wilcox made excellent points. The only small thing I would add to those excellent points is that probably if you really want to make an impact on disparities, the worst place to look is low base rate outcomes, because you're just not going to be able to see if you've done it. You want to tackle the health services outcomes, the larger health services, barriers and access, and make sure that people are getting the treatment they need across all the different groups, which we're very focused on. I think if you try to go in and do that for low base rate outcomes, you're not going to actually know if you've accomplished it. And to me, that's the most important thing, is that you actually, at the end of the day, after you've run a study or after you've done an evaluation, you know that you've actually moved what you want to move. So that would be my suggestion.
I agree with that completely. I also want to say there's value in oversampling for purposes of understanding what's going on. So I'm collaborating with, in the Department of Psychiatry at the Maryland School of Medicine, Deanna Kelly, who specializes in schizophrenia and depression. And we've been doing, a data donation-based study. And for the, we have an overrepresented, and that's a good thing, minority population, and people with the conditions as well. So there are definitely places where where afterwards you can look at the proportional outcomes using the actual proportions in the population. But for purposes of understanding, studying, developing models, and so forth, there's a lot of value in oversampling in order to try to help get around this low base rate problem, as Dan is suggesting.
Maybe I will follow up with a comment from my own. Like, so Holly, like I saw in one of the slides, and correct me if I'm wrong, at the end. So when you had like the breakdown of race, so actually the highest rates were, I think, for white people. I don't know if this was the result of the sample itself or no, because like we sometimes, like when we read these articles, we get mixed messages, right? So they tell us like, no, actually, like the chance of a model to kind of predict a high suicide risk for someone of color is higher, and that's an issue, obviously. Like but then on the other hand, like when we do our studies, like we see kind of different numbers, and obviously this is all based on the data that we work with. So I don't know if you can speak to that. And the other question I have to like maybe Philip is that, like, and somebody asked it as well, is that, for example, with Reddit data and all these social media data, there are studies that says it's mainly by white men of certain age. So I'm not so sure, like I know we are trying to kind of mitigate these issues, but it's really hard, because if this is the data that you get, how can you kind of also even personalize kind of intervention at the end? So I'll start with you, Holly.
Sure. I think what we're seeing nationally lately, if we look at the data, is that while the overall rates have been shifting downward or decreasing a bit in the general population, the trajectories aren't that way for people of color. And so we're not seeing the level of decrease that we'd like to see, that we're seeing in the white population for people of color. And so that is definitely something that has to be on our radar and prioritized. And the issue that we run into, even, in Maryland, where we have a diverse state, is that when we're digging into the data, we still have sample size issues. My colleague, Leslie Adams, is really looking in our data set at suicide among Black Marylanders. And even we're trying to look by sex and other characteristics and really learn from the data. And we run into some data difficulties in terms of sample size, even though we have data from 2012 to present. And so when we look within variation by subgroups by gender and so forth, we run into issues.
Yeah, and I apologize. I was actually focusing so much, including writing some stuff down on Holly's answer, that I forgot the question you were posing to me.
No problem. So the question is that, like you mentioned, that we are trying to mitigate the issues of bias. However, in social media data, especially the data that we usually use, so maybe you remember it.
Yeah, okay. So absolutely, thank you. Things are very skewed. Everybody is, a lot of this workshop and overall all two sessions so far is focused on the value of data and what Coppersmith calls the clinical white space, right? The EHR and so forth data that was discussed at the Maryland warehouse level is an enormously important source of data, but we also know how important it is to detect signal in between clinical encounters. Social media changes, right? You get the, Facebook is an old person thing now, or, whatever, my kids will tell me that anyway, because I'm on Facebook. I think the key thing here, what I want to suggest, and I mentioned this in like the chat among the speakers earlier, especially in light of the fact that the social media companies themselves are not really participating in this conversation right now. In addition to one prong of trying to help get them participating in this conversation, we need another prong with the dominant social media companies and the new ones that the younger populations are in, to figure out ways of doing things without their direct participation. People own their data. People have a right to their data. People can consent to sharing their data for various purposes. They have the right to do that. That's what the data donation platform that we've been using and other people have used does. So one idea I want to throw out here on the table is the idea of finding ways for people to consent to having their data used without having to go to the social media company and say, please do the monitoring better, please do the interventions better, please let us use your API to give us your data. That's an approach that I think is at least worth considering.
Yeah, I totally hear you. Dan, we have more questions for you. So to go back to RWC, one of the people from the audience said, many of us do not know much about RWC. In other places, constant contact has been shown to help reduce suicide. Is that part of the process?
So the primary Real Warriors campaign is not and hasn't been a campaign to specifically reduce suicide. The purpose of Real Warriors campaign is to reduce barriers for service members in getting into care, because there's a concern that there might be stigma associated with getting care for service members. So that's the aim of the program. It's never specifically been to reduce suicide. Now, of course, that is potentially a secondary effect. And the reason I discussed it is because it's an example, and it's just an example. There's lots of programs, and especially when you look at all the different services, right? There's a lot of different ways that there can be programs to try to help service members from different places. It's an example of a program that, as it's seen its social media footprint increase, we've had to think more and more about how we manage high-risk individuals that we engage through those programs. So that's where it came up. And you can find more information about Real Warriors campaign on our website at Psychological Health Center of Excellence, if you're interested, or you can email me and I can provide you all kinds of information.
Excellent, thank you. So there's a question that I think address everybody. So they're asking, what kind of data do you think would help improve your detection? Because obviously every one of you is coming from a different angle. And if you have the option to use all of the data you can, what is your ideal scenario? So maybe Holly, we start with you.
Sure. I do think social media data, and maybe there's some apps now that you can put on your phone that do kind of passive tracking, and they look at your activity levels and your activity through passive monitoring. And those types of data, I think, could be really important and enhance the other types of data that we have been working with.
Oh, thank you. Dan?
I don't have too much to say here. Both Dr. Wilcox and Dr. Resnick kind of approached this issue in their discussions and provided some great information about emerging, not just specific variables, but types of data that would be valuable in increasing the precision of these approaches. So I definitely defer to them on this one.
Well, I introduced myself as a language guy, as you know, so I have a bias. I think that language provides an enormous degree of insight that you don't get from a lot of other sorts of things. At the same time, I'll turn the question sideways and say that just to hammer the point again, right? When we talk about getting the data, it's not enough for one organization to get the data. This is why this warehouse effort is so important, and you haven't spoken about the access to the warehouse, but that's the obvious thing that I, as a person, would like to hear about as a researcher. Getting the data is only the first part. Getting the community working, housing it safely, for example, within secure data enclaves, and then allowing the researchers to come to the data. So now you don't have to worry about dispersing the data and the data management issues and privacy risks and so forth, is a solution that I think is underutilized right now, and we should be doing more of it.
I agree. So given really all the fascinating work that all of you do, and I'm very lucky to actually work with many of you, so that's very nice. So a lot of people are asking about how can they even access these open source codes or models that you have been working on. We totally understand how sensitive the data is, but maybe we can access the models themselves. And I would like to hear from the three of you. So maybe we start with Holly.
Sure. So Dr. Karazi, who's leading a lot of this warehouse, is going to make them all available publicly. And I do believe that Kaiser Permanente's Mental Health Service Research Network does the same thing, that they share all their code as well.
This is great. So maybe like it would be great if we can follow up and then kind of give some links to people. That would be awesome. Like it's always it's something we discussed actually. I think Philip and I at some point it's like to have this kind of a dream repository where we put all the resources, whether it's like literature or code or everything that everybody can access to. So maybe one day we can make that dream come true. So Philip, do you want to follow up?
Well, I mean, I'll mention a paper by, I don't know, Zirichly et al. Talking about a shared task. I mean, there is something we've created called the University of Maryland Reddit Suicidality data set, where we've got data from over 11,000 individuals who posted to the Suicide Watch forum on Reddit, and that equal number of people who never posted there or any other mental health subreddit. We have expert annotations of no, low, moderate, and severe, meaning crisis risk, for 242 individuals annotated by suicide prevention experts, and we've distributed this data set with appropriate sort of governance. They have to apply and show they've got IRB or other kinds of ethical approval. We've distributed this to over 45 teams worldwide so far in the last couple of years. So that's one data set that we've gotten out there. I do want to highlight, though, that language data is difficult to de-identify, and this is part of the problem, right? And so we'll just put the data together and we'll get it out there to people is wonderful when you can do it that way. But if it is not structured data, the idea of disseminating data out to folks is challenging. And that's one of the reasons why I've kind of given up on trying to find ways of doing that for non-public data. And maybe even public data, and think that we should really be thinking about the reverse of creating repositories where the data can live and appropriate governance processes so that researchers and developers and all stakeholders can come in and have access to the data to try to make progress.
Dan?
Yes, I guess just to follow up on that last point, the privacy issues are huge for us, even a national security issue with the data we have. So we would never share service member data. And, we have very detailed information, probably more so than most people do on most populations. But what we do share and what we're entirely transparent about is our own methodology and our summaries of that data in trying to understand these problems in our population. So we've published on some of this before. If anybody contacts me, I can send them some info. But what I presented today is a small part of a larger paper we're working on right now. So that'll be publicly available as well. But as a general rule, in my population, we would never share the confidential type of information that can't be shared about service members. But the summaries of that data to inform other healthcare systems, we certainly share, and we're as transparent as we can be about that.
Great. So maybe to go back to a point like that you mentioned during your talk, it's about like the threshold, like where can you cut off? And this is like a very sensitive thing because it really affects your performance overall. And I think this is something we kind of all face. So especially like Holly and Dan, like if you can maybe talk about like, okay, when you actually changed the threshold, did you kind of have to, like maybe especially in the case of Dan, did you have to change the intervention also, like how it can be? Because of course you don't want kind of a huge intervention especially if you lower the threshold. So how did you adjust like between these two things?
Sure, I could go first. It's a wonderful question. So just as a general, very quick response, that's the reason we did the follow-up analysis, where we essentially adjusted the intervention from like 0% effectiveness to 100%. So no matter how effective it was, and no matter what intervention you chose, you get a range of the possible performance on the population impact, irrespective of the intervention. So, that kind of that kind of makes it so you don't have to worry about that question. But the larger question is a wonderful one that I think about all the time. And it also relates to the sort of decision about what you're actually doing. And what I mean by that is this whole approach is based on identifying a risk threshold, but there are prevention approaches that are directed towards the population or a large part of the population, right? So any sort of concerns or limitations of specific risk threshold approaches don't necessarily translate to approaches which we explore in our system that apply to our entire population, or possibly even just a large chunk of our population. But that's going to be much different than the types of interventions that are typically based on the usual clinical model directed towards high-risk individuals. So I think that's important to point out, because it's that latter thing that we're talking a lot about today. But if you have like a overall population level prevention approach, I mean, you don't even need the risk threshold stuff, because you can just provide it to everybody. And there are some great options out there for that. Over.
And if you really want to get upstream, do you just focus on the top 2% at risk?
Yeah. So we are like, unfortunately, our session is over. I very much enjoyed it, and I'm sure the audience did too. Thank you so much for all the wonderful work. Really, it's amazing to listen to all the work that you have been doing. As I said, I feel very hopeful after listening to all of you. So just quick notes, like we're going to resume at 2. And another thing, like I wanted to bring up, when you come back, remember to refresh your page, because sometimes you think that it didn't start, but it actually does start. Thank you.